Good afternoon, everybody. We're going to go ahead and get started. Thank you for joining us. Today's Cancer Care virtual seminar topic is What is Palliative Care? My name is Annie Gebbe. I'm an outreach coordinator for the Samaritan Cancer Resource Center, and I will be your host and moderator today. This event is brought to you by the Samaritan Cancer Resource Center. We partner with anyone touched by cancer to provide the support they need to live with strength, determination, and hope into the future. Just a few quick housekeeping rules. This webinar is being recorded. We'll be uploading it to our Samaritan YouTube channel in about a week or so if you missed part of it or want to rewatch or share it with friends. All microphones are muted and will remain muted throughout the session. You can use the gray questions menu to write in questions and comments throughout the presentation. We'll be keeping an eye on those. So if you have any questions or comments during, we'll keep an eye on that. If you do have a question, we will reserve time at the end to go over those questions. Joining us today is Dr. Kelsey Terland and Jeanette Hansen, licensed clinical social worker. They both work with the Samaritan Palliative Care team, and we are so pleased to have both of them with us today. I'll turn it over to them now so they can do a little bit more of a thorough introduction. And I just want to give them a very big thank you for taking the time out of their day to teach us about palliative care. Jeanette, you should be seeing that prompt shortly.
Thank you. I'll take just a second to quickly introduce myself while we get our slides up, and then Jeanette will introduce herself and kind of kick off our presentation. I'm Kelsey Terland. I'm the medical director for palliative care here at Samaritan. I've been with Samaritan for about 2 years, but I'm a local kid. I grew up here in Corvallis, went away for several years for my medical training and practiced in Alaska for a handful of years before moving back home 2 years ago. It's really lovely to be back in my home community and practicing the medical specialty that I love. I'll let Jeanette introduce herself and then kick us off.
All right, thank you. My name's Jeanette Hansen. I'm a social worker here at Good Samaritan Hospital. I work in the palliative care program, but I've been with Samaritan for about 12 years. Previously, I worked at radiation oncology with the Samaritan's cancer program. So I've spent about I'm going on 2 years now here in palliative care in the inpatient setting. And it's been a great opportunity to learn lots. So today we're going to give you an overview of what palliative care is, an introduction. I'm going to see if I could move this over here. There we go. And then, you know, as you have questions, I believe there's a place where you could type the questions, and maybe at the end we might be able to do some question and answer online. Let's see. What is palliative care? Let's see, there we go. So palliative care is specialized medical care. Sorry, I'm trying to move things over so I could see the slides here. For people living with serious illness, and is provided by a specially trained team of doctors, nurses, and other specialists such as social workers, chaplains, who work together with patients and other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient and not on the prognosis. Patients can be seen early on, even if for a cancer patient, it could be someone who's early stage. It doesn't have to be someone who is stage 4. Palliative care is appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatment, such as chemotherapy or radiation therapy. Its focus is on providing patients with relief from symptoms and the stress of the illness. And the goal is to improve quality of life for both the patient and the family. We see that especially when cancer steps into a person's life, it's not just the patient who's being impacted, but close family members, extended family members, friends, co-workers. So there are 8 domains of palliative care that kind of guide our practice, things that we look at. And I'm going to go through them here. The first is the structure and the process. So again, we look at people from systems or a holistic approach. You know, we don't see a person just as their diagnosis, but we see, you know, that they are a person, an individual who has a family, who has a community. We take an interdisciplinary team approach. So in that diagram there on the right of the screen, you could see all the different players who help provide care to patients in palliative care. Just in our team here at Samaritan, we have a physician, nurse practitioner, social worker, nurse, and we work with our chaplain. But we also coordinate with the inpatient, occupational, physical therapists, the other medical specialties. And it really is a collaboration of all these different players, and we try and help improve and increase communication between all the specialties. One of the things that we do is a goals of care conference where we sit down with the patient, with the family, and try and formalize through assessments and this discussion what kind of care they'd want and what they wouldn't want based on how they define quality of life for themselves. And the initial assessment, again, is with the patient and family members if they want them to be there. And family really is whoever the patient defines as family. Palliative care is delivered in both the inpatient and outpatient settings. The physical aspects of care, the palliative team will assess the patient's current symptoms and how it's impacting their sense of well-being and quality of life and their functional status. Our doctors will often collaborate with the attending physicians in the hospital in trying to work on pain and symptom management. We also assess the caregivers to find out what their abilities are with the caregiving role, and if they're able to provide the appropriate level of care and how safely, if they're able to help with medication management and medical equipment usage. And of course, there's the psychological and psychiatric aspects of care. And, you know, the one thing we're always trying to assess is how much distress is this diagnosis creating for the person? Is the distress such that it's creating anxiety and depression issues? How well is the person and the family members coping with the diagnosis? Sometimes the treatment, you know? Is there any dementia? Does the person have Alzheimer's in addition to whatever diagnosis they're struggling with? Does the person have any developmental disabilities? Are there cultural considerations that we must take into consideration, and spiritual and existential concerns? The social aspects of care really address the different domains, the social determinants of health. You can see in the diagram off to the left, things that impact care are, where does the person live? You know, do they live in town where they have access to transportation, public transportation, or do they live rurally where they have to try and get a neighbor or a family member to bring them in? How's their economic status? Do they have the resources to help pay for care, or do we need to try and link them to services? Are they connected with any kind of social groups or churches, faith communities? And also trying to assess access to care. Oftentimes we'll have folks coming from the coast. When I worked as a social worker at radiation oncology, lion's share of my time was spent in trying to address transportation issues to even get them to treatment. We also consider the spiritual and religious and existential aspects of care. I like this definition provided by the Clinical Practice Guidelines for Quality Palliative Care. It says that spirituality is a dynamic and intrinsic aspect of humanity through which individuals seek meaning, purpose, and transcendence, and experience relationship to self, family, others, community, society, and the significant or sacred. So spirituality is much bigger than just faith, community, and religion. Spirituality could be, you know, for some folks who maybe don't go to some formal place or practice, but they go for walks in the woods. Maybe art connects them with whatever significant or sacred being there is. And we have a very broad definition of what spiritual is. There are cultural aspects to consider. Assessing and respecting values, beliefs, and traditions related to health, illness, family caregiver roles, and decision-making are the first step in providing culturally sensitive palliative care. So is it culturally appropriate for us to talk with the person who's in the sickbed about their diagnosis, or is it culturally appropriate to first talk to maybe the spouse or a family member? So those are things that we consider. We also realize that culture shapes our attitudes and preferences, and you know what we find permissible and what we don't find permissible in terms of our healthcare. And then we address communication barriers, such as language. If the persons are not an English speaker, then we will get an interpreter to interpret for us. And we work really hard not to rely on family members so that they could just participate in the role as a family member. And we will get a professional interpreter. We also use sign language interpreters when necessary. The other domain of care is caring for patients who are near end of life. And the palliative care team, we assess patients' signs and symptoms that they're near death. We are assessing if they have any signs of distress, discomfort, and we address those. We also assess the family member's skill set, see if they have the skills to, you know, to help with the care, and then link them to appropriate referrals like hospice, who are expert at educating family members and friends and how to provide care at end of life. One thing I want to point out, there's a common misconception that palliative care and hospice are the same thing. Palliative care actually grew out of the hospice movement. Hospice really is the gold standard of care because they also take this multidisciplinary approach to care, and they see the person in their environment and try and support that whole environment. But hospice is just really for folks who have a prognosis of 6 months or less, and they can't be seeking any kind of curative treatments. Palliative care, it takes the same concepts from hospice in terms of symptom management, but it's also used for folks who are undergoing curative treatment. And honestly, we should all be getting palliative care at a baseline from all of our physicians, that we should be looking at the person as a whole entity and, you know, trying to help improve their sense of wellness and well-being. So all hospice is palliative care, but not all palliative care is hospice. There are ethical aspects that we consider. So the core ethical principles of autonomy, substituted judgment, beneficence, justice, and non-maleficence underpin what we do in palliative care. So if the person who is ill is able to make their decisions, we try and find out what it is they want for their care. If for some reason they can't, then we're looking for substitute, for surrogate decision makers, and trying to find out legally who are those people that are making those decisions. And we have to be aware of all the state and federal laws and policies to make sure that we're doing things ethically. All right, I am going to pass this over to Dr. Terland here.
Thank you, Jeanette. While we get kind of control set, hopefully you all can see my screen now. It's the same slide that Jeanette had up. Thank you for kind of giving that overview of what kind of comprehensive palliative care looks like. You know, I think the things that I would stress are, you know, palliative care is whole person care for patients who face serious illness. You know, our goal is to help patients live well while they're facing illness. We help to make sure that everyone's on that same medical page about what's going on, that you're getting the information you need from the doctors involved in your care. So that coordination of care piece that Jeanette was talking about, if, you know, palliative care can be an opportunity to have dedicated time with a clinician to, you know, ask your questions and help make sure that you have the right understanding of your illness and your prognosis. And then it's assessing, what does living well mean to you? How can we make sure we are focusing on that best possible quality of life? But I don't get to define quality of life, you do. What are the things that are most important to you that we want to make sure that that's what we're working toward with our treatments, kind of aligning your medical treatment with your goals of care, like Jeanette talked about. Another big part of what we do is what we call advanced care planning. And so that's what I'm going to talk about a little bit, is kind of what is advanced care planning? And really, it's a conversation. It's making sure that you have a say in your care. It's giving you time to talk with your doctors or your other involved clinicians about what matters most for you, so that we can make sure that we're matching that right medical care to what is important to you. It's also about talking to the important people in your life about the types of care that you want or don't want. It really is about empowering you to feel like you can speak up and have a voice and advocate for the best care possible for yourself. So that's the conversation of advanced care planning, the types of medical care you want, what are your values, priorities, and preferences, communicating those things to the right people. Advanced care planning is also sometimes about the paperwork. And so we'll talk about different documents that may or may not come into play for you, depending on what's important to you and how you communicate best with the important people in your life. So advanced care planning documents that people have often heard about are things like the Advanced Directive for Healthcare, a living will, a POLST form, which we'll talk a little bit more about, and financial powers of attorney. And we'll talk about each of these different pieces and dive a little bit deeper into a couple of them. An Advanced Directive for Healthcare is a document naming a medical power of attorney and putting your voice on paper about the types of care you want. A living will is very similar. It's often done through an attorney, like an estate planning attorney, and it may encompass some other pieces of estate planning beyond just healthcare decisions. A POLST form, which we will dive a little bit deeper into, is actually a medical order. So it takes your values, priorities, and preferences for the type of medical care you want right now, and then turns it into a medical order to make sure that that's followed by your healthcare team. A financial power of attorney is another document that's often helpful for patients who are facing serious illness. Sometimes when people become ill and are hospitalized, it's difficult to, manage your own finances, to get to the bank, to apply for different health insurances. And having a financial power of attorney designated gives someone you trust the ability to help you with those types of things. A financial power of attorney and a medical power of attorney are two separate things in most documents. So if someone has a financial power of attorney, often that person named does not have any authority for making medical decisions. You have to have the Advanced Directive for Healthcare or a living will that designates a medical power of attorney in order to have someone who can be your voice for medical care. So I like to make that distinction very clear for people, because often we find patients come into the hospital and they say, yes, I have power of attorney documents. And we take a look at them and it's just financial power of attorney. So no one designated to make healthcare decisions. So important to look at your documents if you have them in place and make sure you have someone designated in each of those roles. For some people, they choose two separate people, someone to do medical decisions, someone to do financial decisions, but some patients designate the same person to do both, and either is okay. So what is an advance directive? This is the document that myself and Jeanette and our team as the palliative care team often help patients to put into place. There are two key components to an advance directive. One is naming your healthcare representative. I always encourage patients to name the person who you feel knows you best and who you would trust to be your voice for healthcare decisions in times when you can't speak for yourself. Of course, as long as you're able to speak for yourself and make your own medical decisions, you are your own decision maker. This really only comes into effect when you become so ill that you can't make your own decisions. Sometimes that is temporary. People have an acute illness and become confused, and as we treat that acute illness, their confusion resolves, and they again regain their ability to make their own decisions. But in illnesses like dementia, for example, it's so helpful to have named a healthcare representative, because often once someone who is experiencing dementia loses their ability to make their own decisions, they don't regain that ability. So putting this type of document into place early while you have the capacity to make these decisions is really important. And again, it's someone you trust to be your voice. We're not asking our healthcare representatives to make decisions based on their own values or what they would want. It's really being the voice of the patient and telling the healthcare team, what would this patient say if they could speak to us now? That's the role of the healthcare representative. That's part one of the advance directive. The second part of the advance directive walks you through some specific healthcare decisions. For most patients, we encourage doing this early. So often these healthcare decisions that we're looking at aren't decisions for right now in the moment in your current state of health, but are decisions for the type of healthcare you would want in the future as your health changes. So what you want right now may be different than what you put in your advance directive for what you would want in the setting of facing a terminal illness or an advanced progressive illness or being permanently unconscious. And those are the different healthcare decisions that the advance directive often walks patients through. And thinking about what types of life-sustaining treatments, such as artificial nutrition and hydration, breathing machines, dialysis, those sort of very advanced medical therapies. Would you want them or not want them if you had a terminal illness? Would you want them or not want them if you were permanently unconscious and it wasn't felt that you were going to regain consciousness? Would you want these sort of more advanced therapies to prolong your life in those settings? Very personal decisions that are really based on what your personal values are. And so thinking about that and what's most important to you, what are the things that give you quality of life? What are the things that make life worth living? And then thinking about how advanced you would want your medical care to be if you found yourself in one of these situations. The Oregon Health Authority has an advance directive available on their website that can be printed by anyone free of charge and then completed. In order for it to be made kind of a legal complete document, that document does need to be notarized or witnessed by two people. If you choose to have it witnessed by two people, the people who are doing the witnessing can't be the person who you've named to be your healthcare representative. So it needs to be two different people than the people who you've named in the document. Of course, you're encouraged to give a copy of the completed document to your medical team. We scan these into the medical record so that they're available to anyone who has access to Samaritan's healthcare records. So if you were in the emergency department, in the hospital, in the clinic with Samaritan, your clinicians would be able to find these documents. But then, of course, also to give a copy of the document to the people who you name as your healthcare representatives. So I think of, advanced care planning is having the conversation, talking about what's important, and then putting it on paper. So So both of these pieces can be really important parts of doing comprehensive advanced care planning. I mentioned we'd dive a little bit deeper into what a POLST form is. So POLST stands for Portable Orders for Life-Sustaining Treatment. Often it's a form that has a bright pink border that people put on their refrigerator or on the wall or the door to their bedroom. And this is the form that turns medical wishes into medical orders. So different from an advanced directive, which is talking about what you would want in a future healthcare situation. The POLST says, this is the type of medical care I want right now, and here's my doctor's order to make sure it happens. It's really intended for patients who have serious progressive illness or people who are older and frail and might not want all available medical treatments. I often think of this, most people are kind of familiar with the term DNR, or do not resuscitate. We call that a code status order. Everyone who's admitted to the hospital has a code status order, either for full code, meaning we would attempt resuscitation, or DNR, do not resuscitate. If you have a DNR order when you're admitted to the hospital, that goes away when you're discharged from the hospital, and the POLST form needs to be put into place to be your DNR, do not resuscitate order for in the community. So it covers, what type of medical care do I want in the event that my heart stops beating and I stop breathing if I've died? Do I want to be resuscitated, or do I want resuscitation attempted, or do I not want those things done if I'm at the end of my life? Do I want to be DNR? The POLST then also covers, just as important, how do I want to be taken care of if I'm getting sicker, but I'm still alive, my heart's still beating? And it's a range of things. There's 3 options from I want full interventions. If I become sicker, I want to go to the hospital. If I'm still alive and having trouble breathing, I'd want to be put on artificial life support, a breathing machine, to help see if I can get better. The other end of that spectrum, the kind of third choice on the form, is what we call comfort measures only. So this is for patients who say, I really, at this place in my life, I value being at home and being comfortable. I don't want to go back to the hospital for changes in my health. I'm accepting that a natural death is coming, and I want to be in my home and comfortable. And then there's a middle option on the form that is selective treatment, saying if I get sicker, I want to go to the hospital. I want, kind of reasonable medical interventions like IV fluids or IV antibiotics. But if I get so sick that I would need to be on artificial life support, like a breathing machine, I don't want that. So a range of options that can be selected on the POLST form. This form is filled out in a conversation with your healthcare clinician, your physician, your nurse practitioner, a PA, or a naturopathic doctor can all sign this form. And it's not set in stone. If you change your mind, this form can be voided at any time. And I think that's really important for people to know. Kind of comparing and contrasting an advanced directive from a POLST form. Again, an advanced directive is really recommended for any adult to communicate who you trust to make decisions and what those decisions would be if you found yourself in those certain medical situations, whereas the POLST form is really meant for patients with serious illness or who are elderly and frail and are desiring limitations on treatment. The advanced directive is considered a legal document, whereas the POLST is considered a medical order. The advanced directive you can fill out and you sign it. It needs to be notarized or witnessed, whereas the POLST is filled out by your medical provider and signed by them. You don't need an attorney for either of these documents. You may work with an attorney for estate planning and a living will. That would never include a POLST, which has to be done by your clinician. You keep your original copy of your advanced directive. As I said, we scan a copy into the healthcare record and encourage you to give copies to your healthcare representative. You're also given a copy of your POLST form if you have one of those filled out to take home and post in your home. And then we keep a copy with the medical record. And then Oregon has a POLST registry so that if you were in a different community in Oregon, and became ill, they would also have access to your POLST form through that registry. Both of these things are things that can be changed. I think that's important to stress. And the advanced directive is the form that allows you to name a healthcare representative, while the PULSed form asks us as clinicians to fill out who was a part of the conversation, and there's a place to put kind of who is the emergency contact. The PULSed form does not designate a healthcare representative. So that's not the form to put into place in order to designate someone to do that for you. So that's kind of my discussion on advanced care planning. I'm happy to chat more about it in questions at the end, but I want to kind of pivot back to kind of that full spectrum palliative care. One of the questions that we often get is who pays for palliative care if I'm going to receive a referral to palliative care or a consult in the hospital. Palliative care is a fee-for-service provider billing under Medicare Part B with patient copayment. So if you have, if you're a Medicare patient and you have a copay when you see your oncologist, you would have a copay when you see palliative care. It would be no different than that. Palliative care programs often do contract with insurers or other payers to create kind of a range of different payment options. One of the beautiful things about palliative care is that it is an interdisciplinary specialty. And so when you're referred to palliative care, yes, you get to see our physician or our nurse practitioner or PA, but you also get to see our nurses and social workers, our psychologists, our care coordinator. And we create contracts with payers to help make sure that the whole interdisciplinary team is supported. The prevalence of palliative care is rapidly changing. It's widely available in the hospital, so in inpatient settings, and it's a little bit more limited, but growing rapidly in the outpatient setting. So here at Samaritan, we have inpatient palliative care consultation services at Good Samaritan Regional Medical Center in Corvallis, at Albany General Hospital, and Lebanon Community Hospital. So if you're admitted to the hospital and you have serious illness and you feel like it would be helpful to talk with someone from palliative care about your medical situation, about your prognosis, about what's most important to you, and making sure that you're getting the types of medical care that you want, about connecting to resources outside of the hospital for when you discharge from the hospital, or talking about transitions in your goals of care. If you feel like you've been pursuing, disease-directed curative treatment and those wishes are changing and you want to talk about pivoting towards something like hospice, and you're in one of these hospitals requesting a palliative care consult, those are things that we can help you with. Outpatient palliative care is a little bit more limited in our area. So with Samaritan, we have what we call a community-based palliative care program that serves patients who live in Lynn County. When I say community-based, that means that we see patients in their home or wherever they call home. If they live in a facility like a assisted living or a nursing home, we're able to see them there. So they don't come to us in clinic, we come to them. They maintain a relationship with all their other doctors, and we're that added layer of support to help them kind of navigate their serious illness and help them to improve and their best possible quality of life. Again, that's for patients who live in Lynn County. We do have a small outpatient clinic also in Lincoln City. So different than Lynn County, where we're community-based, seeing patients in their home. In Lincoln City, we're clinic-based, so patients come to us in clinic. That clinic's able to serve patients across Lincoln County. We do like for the patients to come to see us in person, at least for that first visit. So being able to get to Lincoln City for that first visit is important. And then we can use telemedicine if getting into clinic is burdensome for follow-up visits. Samaritan Palliative Care accepts all insurers. Another option in our area, well, the other options that I'll talk about, I know a little bit less about, admittedly, as a Samaritan physician, but Lumina Palliative Care has also a community-based palliative care program in Lynn County, Benton County, and parts of Polk County. They're limited by insurer, so they will serve patients who have IHN, which is our local Medicaid, as well as Samaritan Health Choice and commercial plans. Signature Palliative Care, many people are familiar with Signature from their home health teams. They also have a home palliative care team. They serve patients in the Mid-Willamette Valley and accept all insurers. And then Willamette Vital Health, I think they used to be called Willamette Valley Hospice, has a small palliative care program, also community-based. They're based out of Salem, but do serve most parts of our service area as well. So several different options. Some depend on where you live, some depend on what your insurance is. And if you have questions, I know we're happy to help be a resource and guide people to try to find what services they might qualify for. If you do have questions and you want to reach out to us, 2 different phone numbers for Samaritan Palliative Care. The first number reaches our inpatient hospital team at Good Sam in Corvallis. The second number would reach our inpatient hospital teams in Albany and Lebanon, also our community team in Lynn County and our clinic in Lincoln City. I think of that number as kind of the main number for patients who have questions about, just kind of general questions about palliative care, the 541-812-5020. And we also have phone numbers for Lumina and Signature on here if you prefer to reach out to them. And that's what Jeanette and I have for you. I really appreciate the time to be able to talk a little bit about what palliative care is, that important component of advanced care planning, and then a little bit about services in our area. And we would love to take any questions you might have.
Thank you both. And we do have time for questions, which is great. Those of you who are listening, if you want to write in questions and comments into the gray questions menu, we'll go over those momentarily. In the meantime, I'm just going to quickly go over some information and resources regarding the Samaritan Cancer Resource Center. You can reach us by phone, on the website, email, or social media. We have Facebook and Instagram. You can also visit either of our in-person locations in Albany or Corvallis. We have a couple upcoming events to round out the year. In 2 days, we have Cancer During the Holidays with social worker Amy Copa. If you haven't registered for that yet, it is free and there's still time to register. If you have our newsletter link, the registration information is in there, or if you have any trouble, just give us a call or email us so we can help you get that set up. We also have relationships with diabetes and cancer, which will be presented in Spanish in December on the 12th. And okay, I'm going to go over the questions now. If someone has questions about if palliative care could help them, how can we get them connected to you?
Yeah, so I would recommend giving them that phone number, the 541-812-5020, to ask questions about our services and if they would qualify for any of our programs. We do require a referral from another clinician, so from your primary care doctor or your oncologist. Because we are an extra layer of support and don't assume management of the patient's serious illness, but really help with support around quality of life and symptom management, we do need to have a partnership with the other clinicians involved in your care. But reaching out just to ask general questions, that 812-5020 number is the best number. Our care coordinator, Allie, is a great resource. And then asking for a referral from your primary care doctor or other medical specialist.
Thank you.
Yeah.
The next question. Do you also work with the Veterans Home in Lebanon?
Great question. So our community-based program, like I said, we see patients in their home or wherever they call home, and that includes at the Veterans Home. So we do have patients there. Those patients often, when they're admitted to the hospital, end up across the street at Lebanon Community Hospital. That's where I have my clinical time, and so I certainly see veteran patients when they're admitted to to the hospital in Lebanon or any of our Valley hospitals. But we do go into the veterans home with our community-based program.
Okay.
And we have a great relationship with the geriatrics team, who I think does most of the general medical management for our patients in the veterans home.
Oh, wonderful. Can any patient access these services, or is it limited to a certain diagnosis or stage of disease?
Great question also. And I think this might be something that patients may have heard other things about what is available, because it used to be that we were limited by diagnosis. So it used to be that our community program in Lynn County only served patients who had symptomatic heart failure. That's kind of how that program started as a pilot program. This fall, we expanded and served patients with any serious illness diagnosis. So we're not limited by diagnosis in any of our service areas. So any of the inpatient hospitals will see patients with any serious illness diagnosis, and same with our 2 outpatient services, not limited by diagnosis. I mean, patients do need to have a serious illness. And I often think, patients who have, other primary drivers for the majority of their medical care, so complex mental health, complex substance use disorder, those things often need to be managed by other specialty teams. And it's when those things become life limiting, and people would benefit from a really robust goals of care conversation. That's when our team can be helpful.
Thank you for clarifying. That's great that it's open to more people now.
Yeah, that was a change just last month, so that's pretty new.
Wow, that's exciting. How does palliative care work when the patient goes to multiple facilities?
I guess a little clarification on what they mean by facilities would be helpful. Certainly if we see someone admitted to the hospital and do our palliative care consult there, and then they discharge to like a skilled nursing facility for rehab with a plan then to discharge back home, depending what community they're in, we can often hand off from the inpatient palliative care team to the outpatient palliative care team, so that you can continue to have palliative care services. But those outpatient services are really specific to where people live. And so it's figuring out what programs exist where someone is discharging to. For patients who are, seeing their PCP and their oncologist and their cardiologist, we're absolutely communicating with all of the members of the medical team who are involved in a patient's care. And certainly in the outpatient world, visit burden is a real thing, having to go to all these different medical appointments. And our hope, especially with our Lynn County program being community-based, is that we can alleviate a little bit of that visit burden by coming to you. But you continue to go see your other medical specialists, and we can help just with communication and support as you're navigating all of those different medical appointments. Jeanette, do you have anything else you would add to that?
Yeah, I think the only exception is, let's say that the person was living in an assisted living facility in Albany, and then they needed a higher level of care, but the only higher level of care was maybe like in Salem or Corvallis. Then we'd have to probably try and find another palliative care program to serve them. Yeah, the geography limitations often have to be navigated and will dictate which team you can continue to have a relationship with. And I think thus far, many other facilities welcome either palliative care or hospice coming in to help, provide that extra layer of care and support. So, yeah.
And I believe you touched on this, but could you clarify, are these types of services available in a telemed or virtual type of format?
Yeah, so we do telemedicine. Serious illness conversation is a really personal, kind of intimate conversation. And so it's important that we build good relationships with our patients in order to be able to have, high quality conversations around these difficult topics. So when possible, we do prefer to do it in person. It's just easier to build relationship that way. But we absolutely have the capability to do telemedicine.
It sounds like telemedicine follow-up is what I had heard you say earlier in your presentation.
Yeah, for Lincoln City, I know Teresa. Yeah, in Lincoln City, I know Teresa, our PA who runs that clinic, who's extraordinary, really prefers that first visit be in person, really for that relationship building purpose. And especially if we're going to weigh in on symptom management, like pain management, it's really helpful to be able to do an exam. And so that first visit we prefer in person, but can then pivot to telemedicine if that's easier for people.
Great, thank you. We've got another one here. Do advanced care planning documents expire?
Good question. So no, they don't. When you fill out an advanced directive, Jeanette, correct me if I'm wrong. I think there is a place you can put that it expires at a certain date, but I would say I don't see patients do that. And certainly if you fill out an advanced directive and your wishes change or the person you want to be your healthcare representative changes, you just fill out a new one. And it's the most current advanced directive that is the document that we use.
Yeah, and actually I encourage folks every couple of years, take that advanced directive out, take a look at it. It's like, okay, this has changed in my health. Does this still make sense? Yes, no. And then all these people who I designated as my representatives, are they, still in the area? Have they moved out of the area? Or, is that still the person I think who would best be my voice? And so that's a good time to make those changes. So I encourage you, if you have an advanced directive, take it out, take a look, and if everything's fine, put it back. Don't worry about it for another couple of years or until something significant changes in your life.
Yeah, I encourage the same thing. Review it every few years. Make sure it still reflects what you want it to. Your healthcare representative doesn't have to be local. If the person you trust to make your medical decisions lives in Florida, that's okay. There are always, a couple extra little challenges when someone's not out of the area, but if that's the person you trust, that's okay. The PULSE form also doesn't have an expiration, but I do think that the registry removes PULSE forms that are older than 10 years old every so often. And I know they're getting ready to do that next year, to remove documents that are older than 10 years old. They are going to notify patients and the clinician who filled out that PULSE form if it's being removed from the registry, so that if for some reason you had a PULSE form and it was 10 years old, that they just would want you to fill out a new one.
Wonderful, thank you. I don't see any more questions at this time, but I'll slowly transition to the next screen if anyone wants to throw in another question. We do have a survey that will go out after the presentation. If you wouldn't mind filling that out, we would really appreciate it. It gives you an opportunity to tell us what you liked about today's presentation, things we could improve on, or topics you'd like to hear in the future. We really appreciate any feedback that you have. And if no one has any more questions, you may log off. Thank you so much, Jeanette and Dr. Terland, for being here today. This is such an important topic, and we really appreciate your time.
Thank you.
Thank you, and thank you for your time as well.
Of course. Well, everyone, have a wonderful day. If you do have questions that pop up, later today that you forgot to ask, feel free to email us at cancerresourcecenter.org. At samhealth.org, and we'd be happy to field those questions through the palliative care team for us to answer with you privately. So if something comes up, feel free to call us or email us. And we will see you next time. Thank you so much, everyone, and have a wonderful day. I'm now ending the webinar. Thank you.